Welcome, my dear, fifth stage Medical College Mason University. Our lecture today about nephrotic disorder. It is complete to be an ideal lecture for you. Background, we have factor V Leiden, prothrombin 20, 210, protein C and S, antithrombin deficiency, heparin-induced thrombocytopenia. The most important topics is antiphospholipid antibody syndrome. The causes of venous thrombosis. The most frequent hereditary cause for venous thromboembolism are factor V Leiden. Leiden is a city in Germany in which the first disease was described. Prothrombin gene mutation account for 56% of the cases. The major acquired risk factor for VTE include prior thromboembolism, recent major surgery, trauma, immobilization, antiphospholipid antibody syndrome, malignancy, pregnancy, oral CB pills, and myeloproliferative disorders. And this is the schedule for risk factors for developing thromboembolism or venous thrombosis. Clot formation, as you noted here, there is vessel wall, platelet adhesion, fibrin formation, and this vessel wall contraction and platelet aggregation predispose for thrombus formation. What are the predictors for the pretest probability of DVT, deep vein thrombosis? We have a score, and score more than 2, high probability of DVT, and active cancer, bedridden, paralysis, recent bedridden, surgery, localized tenderness, calf swelling, pitting edema. Alternative diagnosis is -2, so more than 2 is high probability of DVT, and too much anticoagulation in thrombotic patient can lead to bleeding. So we should be in this area, balance area, neither thrombosis nor bleeding. Commonly encountered acquired risk factors: HIT, heparin-induced thrombocytopenia, surgery, mobilization, malignancy, pregnancy, oral contraceptive, estrogen replacement therapy, lupus, systemic lupus, erythematosus, anticardiolipine, antibody, obesity, and smoking. The most common hereditary risk factors for thromboembolic phenomena is activated protein C resistant. Nearly always the factor V Leiden mutation may be heterogeneous or homogeneous. Prothrombin G 220 2010 A mutation may be heterogeneous or homogeneous. Protein C, protein S deficiency are essentially always heterozygous. Protein S heterozygous, and antithrombin deficiency essentially always heterozygous. Most people have more than one risk factors or factor for thrombosis. At birth, factor V Leiden, genetic disease. At 25, oral contraceptive, let us consider this is female, and increase the risk of thrombosis. At 35, leg injury. At 43, plane ride, leg injury, oral contraceptive, factor V Leiden. These are factors that increase risk of thrombosis. Activated protein C resistant, the factor V Leiden mutation. As you see by this diagram, this is endothelial surface, and this is tissue thrombomodulin, protein C and S, essential for thrombus formation. Whenever you have factor 5 and factor 8 activated, they are not activated, it will be increase in the protein C and S concentration, and this lead to thrombus formation. So this diagram shows us how protein C and S enhance thrombus formation. So anticoagulation, procoagulant activity, factor 5. Factor V Leiden mutation produce change in amino acid sequence 506. The factor V Leiden mutation does not affect the procoagulant activity of factor 5, resistant to activated protein C and factor 5 Leiden mutation. It is found about 50% of Caucasian patients with familial thrombophilia, 20% of all Caucasian patients with DVT, and about 5% general Caucasian population. Factor 5 Leiden is the most commonly encountered risk factor for DVT. Its role in arterial thrombosis is not so clear. Resistant to the activated protein C and factor 5 Leiden mutation, oral contraceptive increase the risk of thrombosis in patient factor 5 Leiden. It increased the risk about 30-fold. Mutation at position 20, 210 prothrombin gene associated with elevated prothrombin factor 2 level, high prevalence, 3% of general Caucasian population, 10% of Caucasian population with thrombosis as a cause, 20% of Caucasian patients with familial thrombosis, threefold increased risk of thrombosis in heterozygous patient. So as I mentioned before, protein C and S are essential for thrombus formation and activation or deficiency of these proteins lead to thrombus formation. Antithrombin pathway, as you notice here, antithrombin, this is factor 10, activated factor 10, and this is thrombin, and these are the diagram show how antithrombin and heparin work. Antithrombin deficiency patient may moderately to severely heparin resistant. Why? Because the heparin depend on thrombin or antithrombin for its action. So patients with antithrombin deficiency have less response to heparin. In this case, you should use another drugs or give high dose of heparin. Prevalence of inherited risk factor for thrombosis, factor 5 Leiden, as I mentioned, 5% population, prothrombin 20 to 110, 2.5, low protein C, low protein S, 0.2, low antithrombin, and even 0.2. Acquired conditions or treatment that decrease both the anticoagulation factors and the procoagulant factors, clot formation, protein C and S, antithrombin low, liver disease, all these low, comadrine, warfarin, protein C and S low. So during initiation treatment with warfarin, comadrine, we should use heparin for the first 5 days to prevent protein C and S deficiency caused by comadrine, and this causes paradoxical thrombus formation. DIC, protein S, antithrombin low, vitamin K deficiency, protein C and S low, heparin low, antithrombin, oral contraceptive, estrogen therapy, pregnancy, acute phase reacting, all cause protein S to be low, and this enhances thrombus formation. HIT, as I mentioned in the previous lectures, bleeding disorders, no need to be mentioned again. Just mention this. Proposed mechanism for the pathogenesis of HIT, heparin-induced thrombocytopenia, is that autoantibody attached to the platelet receptor, FC receptor, and causing immune complex and then aggregation of platelet in the microcirculation. So the consequence of thrombosis in HIT are often severe, about 60% recovery, mortality about 30%, and permanent disability can be ended with amputation around 30%. Before we continue to antiphospholipid antibody syndrome, I want to mention that these causes of thrombotic disorder, factor 5 Leiden, activated protein C, and prothrombin gene mutation, these are common in Western countries, and they are less common in Middle East and Asian population. So the frequency of these mutation or these diseases are much less commonly seen in clinical practice in our patient or in general in Asian population. Now the next topic will be talk about in the next lecture which is antiphospholipid antibody syndrome. We stop here and we are ready for any question. Thank you.